Julie. Okay. Well, good morning, everyone. I hope you've got all the papers on your computers and you can see everything.
Yep.
Just to remind you that this is a public board meeting, and the issue of being available to the public to scrutinise our affairs is very important, and we have decided to record this meeting and put it on the website with the minutes and appropriate papers so the public can see it. And at the end, I'm not sure it'll be this part or the in-committee part, we'll have a little discussion about how we go things going forwards. But my understanding is that so far we're content that the July meeting of the board will be live on video with a chance for the public to pose questions to us prior to the meeting that we'll try and answer at the meeting, but we can just finalise that in the coming few weeks. So that's my welcome. Apologies, Julie.
Only Mahmuda didn't send her apologies, but she's not joined us, so that's the only person.
She may have a technical problem.
Yeah.
Okay. Declarations of any other business for the agenda?
No.
Okay. Declarations of interest in the agenda items or amendments to the register of interests?
No.
Oh, okay. Minutes of the meeting 5.1 held on the 11th of February and the 14th of April. Any corrections to either, please?
Not from me.
No,
none from me.
Okay. The action log and matters arising. I think, as far as I can see, they're all either done or waiting to, are not yet ready. But there was one, which was the second one on page 30. It just was due. This is about equality strategy report due in April. It says to be reviewed as part of the strategy review. I just wonder whether you can get clarification of when that's going to happen.
Shall I take that?
Catherine, if you could, please.
Yeah. So I think I'm working to the expectation that we will need to come back to look at our 3-year strategy when we come out of the recovery phase. I think whilst a lot of what we've agreed in the strategy will still be valid, we probably will need to look at refreshing that. And at the moment, I'm thinking we're probably looking at a September-October timescale on that. And that would be true for the equality diversity strategy as well. I just want to caveat that rather depends on what happens over the next few months. But that's the timescale I'm working to provisionally at the moment, if that's agreeable.
Everyone happy?
Yeah.
Okay.
Thank you.
I don't think there's anything else I've got in the action log. Anyone got anything they want to raise?
Yeah, just quickly, Martin. There is an action which is on page 31. It's the meeting dated the 12th of the 11th and the finance report. So you might recall that way back when we felt that there was a need to take a look at the number of admin staff that had gradually increased over a period of time, and just see whether or not there are some efficiencies to be brought about by taking a look at that. And it is right that the finance, that Alex and his team did present a report to the finance committee. But it was certainly at a time when we were deep into COVID planning and so on. So the report didn't get any serious attention. So the so what, if you will, is yet to come. So doing an analysis of that data and determining whether or not there are some efficiencies that we can bring about is something that remains on the agenda.
Yeah, thank you very much, Naomi. I'm sure as we go forward and as the world clarifies a bit and we learn some of the lessons, positive and negative, from the recent events, that there'll be quite important to have quite a review of all this to make sure we go forward in the longer term, learning those lessons and being confident in our cost base. Okay, perhaps then we could move on, if everyone else is happy, to page 37, the quality assurance processes during the COVID-19 pandemic. And Debbie, could I ask you just to take us through this, please?
Yeah, so thanks, Martin. The paper outlines the national guidance that was issued as a result of the pandemic and organisationally how we've responded. You'll see from the paper that actually we're still doing pretty much all of our quality and safety processes to provide assurance. I'll let Minu talk a little bit more about the ethics and clinical strategy bit, because he chairs the clinical strategy group, and that's one new element that has been brought in as a result of the pandemic. But otherwise, what I would say overall, we're probably seeing less activity in some things like datex and complaints, but then we're seeing less patients at the moment. Our wards are quieter. So it's not totally surprising, and we're seeing more activity in things like safeguarding and infection control, but we're still doing learning and putting in any immediate actions as we always would if there's any quality or safety issues. There was attached at the back of the paper, some guidance came out on the 1st of May, which is quite late in the day, but it wasn't actually highlighting anything we weren't already doing. So that was all I was going to say, really. I'll let Minu talk about the ethics and strategy, and then happy to take any questions.
Yeah, just before Minu comes in, just to say, I think it's a very comprehensive paper, and it's very reassuring, I think, to see that, you know, the normal processes, as much as we can, are being carried on, you know, accepting that some can't, and also that as the guidance comes out, it reinforces the fact that we've been doing the right sort of thing, which is good.
Yes.
So thank you for that. So Minu, shall we invite you just talk about ethics, and then we'll come back for any general questions on the whole paper.
Thank you, Martin. Just before I go into ethics, I just want to point out that there are some functions which remain unchanged. So just to give a brief about the mortality review, our underlying governance and review of mortality or deaths in the trust and the learning remains unchanged, even though we've sort of released the clinical directors from the burden of some of the work. But in addition, we have implemented a number of other requirements that have come down nationally related to COVID. So business as usual, plus additional governance and assurance. And the same applies to national clinical audits, which have been published just before the COVID period. We are processing those and getting them through QUAC, all our NICE guidance, which came up to the point of COVID. And of course, all the NICE guidance now is COVID related. So I think my sort of simple message is that we have not actually suspended, at least from my point of view, and I'm sure the same applies to Debbie, any of the governance functions. We have taken on more in relation to COVID. And that has been a choice, because we could have suspended, a number of trusts have suspended a number of those functions very justifiably based upon some national guidance. Moving on to the ethics process, the context of this is that in a pandemic, you know, there's always this struggle between the needs of individual patients and then the wider sort of larger group of patients. And there was an assumption that some of very difficult ethical decisions would need to be made if we had a surge, which in a sense did not happen. Nationally, there seemed to be, if not an explicit message, there was a messaging that there would not be any national ethics guidance coming through, and hence regionally they would have to manage it at an individual trust level. So we set up an ethics group, which was led by Guy Northover, our lead clinical director, and the strategy group, which received information from the ethics group. And you'll see from the paper, we've received a number of proposals, suggestions. We have considered all of them. We have rejected a fair few, which we did not think required either ethical discussion or that they were not in the correct spirit of the ethics for patient care. But we have picked up some and set out guidance to help our clinicians to manage situations which may arise during this period of COVID crisis.
Okay, thank you very much. Colleagues, any questions for either Debbie or Minu on the paper?
No, I thought it was very clear, Minu and Debbie.
Thank you.
Very good.
Martin, may I respond?
Please, Dave, please.
So first of all, I thought the paper was exactly what we needed. I thought it was very pleasing, very clear summary, the clearest summary I've read so far. So great. I suppose all I would say is it's my job to be concerned. We should continue to worry about quality. We know that people are distracted by COVID, that there's a bit of tunnel vision, particularly in the acute sector. People are also working in areas that are different, so they're not necessarily working in their normal areas. And an important part of quality is consistency and process and data. And the paper does explain, while that continues, it has in some areas been suspended or reduced or perhaps watered down. And then when you take into account that our normal quality indicators, the baseline is changing, so we may not have the stats that we're used to. So I think it's just a caution that we're all clear about, is that times like this are when quality tends to slip, and we can't allow that to happen. But I think the paper has answered all my questions. Thank you.
Okay, thank you very much, David. I've just prompted me, Minu and Debbie, to ask, in terms of the things where full process has been suspended, quite properly under the current circumstances. It's going to be a bit of a catch-up, isn't it? To go back and review some of these. Is that clear how that recovery is going to happen yet, in terms of serious incidents and such like?
So serious incidents haven't been suspended at all. Okay. In totality, we're still doing initial findings reviews, and we are still progressing SIs as we need to. We're probably taking a slightly different approach to some of them, but we are using people that are shielded and others to actually look at some of the processes. What we can't do necessarily is see loads of people face to face as part of that. So we're using other means to actually test that out rather than suspending it. So there will be a few to catch up on, but we'd have done a lot of the groundwork with them already. So there's none that I would be worried we're not looking at for immediate learning, anything that needs to be done differently straight away.
Yeah, and from my parts, the assurance directorates, actually there is nothing that we have suspended. The only places where we are unable to progress is directly related to the national suspension. So if there are no more national clinical audits coming, we don't get the audit protocol, we can't do the audit. If there are no more national guidelines coming on anything but COVID, we can't do anything about guidelines for NICE, etc. So I need to be clear, no, we have not suspended or watered down anything. What we've done is, in a sense, I can speak for myself, but I'm sure Debbie can. We have individually taken on a greater responsibility for some of the sort of frontline governance work to take the load off some of our other staff. So let's say for clinical directors. So I now review much more in depth. The patient safety team, which sits under Debbie's directive, does much more analysis upfront to give us that information for the mortality review. But there are some, so in response to your question, Martin, there will be a bunching up if the national system opens the tap suddenly in September and says, well, now you have the national audit on valproate from June, July, which you need to do in September, plus 4 other audits, which were due in the autumn together. Now, you would hope that that wouldn't happen, and hence that bunching up should not happen there. If it happens, we are ready. Our team is ready to pick these up because we have sort of factored in that there will be a busy period there. But for the current period, no, there is no watering down or reduction in the governance processes from my point of view.
Thanks for the clarification from both of you. Anything else people want to raise before we move on?
No.
Just a quick question to Minu and Debbie in terms of the continuity of the governance structure for ethics. Clearly that's been stood up. Is our intention to sustain that for a period of time and then perhaps stand it down, or just a sense of how you intend to go along?
Sure. It's very relevant, Naomi, because that is our observation. I'm sure Martin would also have observed the first sort of 4 weeks, we received a large number of applications which we had to go through. They are sort of a trickle now, and probably a meeting on Wednesday may have one application, if at all. I think we're not going to stand it down entirely because some issues will come up. I can be almost certain that this is not the end of COVID. It is simply a quiet period between two storms, and a further one will happen. And we will hopefully not have to make those difficult ethical decisions of what do we do if you're one syringe driver and two patients who need it at the same time. But, you know, we have to be prepared for those. So we will not be standing it down. We may not have as frequent meetings, but there will be the undercurrent and the principles which will be available, and we are ready for, you know, in a sense, restarting it as soon as.
Thank you.
Hopefully, we won't have the need, but we may have now.
Okay, thank you very much. Could we then move on to page 51, the patient experience Q4 report? And Debbie, I think it's you again.
It is. It is. So this is our usual Q4 patient experience report. Although some activity changed a little bit at the end of March. So, for instance, nationally, Friends and Family Test was suspended, and the Ombudsman stopped looking into anything. I don't think that's impacted really on this particular report. It was so near to the end of the quarter. Highlights I've put on the front sheet. Complaints remain small numbers, and it's not really possible to draw any particular trends or conclusions from them. Just to say, the Friends and Family Test question was due to change in April. That's been put on hold at the moment, but I think it'll be interesting to see if that does have an impact, particularly on our mental health percentage satisfaction, which is a little bit, about 83%, is slightly lower than the national mental health average at the moment, which sits around 89%. But what we seem to get a lot of when I've looked at it is a lot of people saying they just don't know. So they don't say they're likely to recommend. They don't say they're not likely. They just say they don't know. So I think changing the question to how was your overall experience might provide us some more useful data than we get at the moment. And the other thing I just wanted to update was the work around the new tool. So we did manage to complete the first stage of the process, which was to actually go out to patients and staff and see what sort of things were important to them, how they'd like to be responding to any questions. And I've just had the draft report in of that, so we'll now be able to progress that tool to the second stage, go out to tender to actually get the tool put together, for loss of any other word. That was all I wanted to say, really, and I'm happy to take any questions.
Just on that point, I think it's really, we look forward, I think everyone looks forward to seeing this new tool, which hopefully provide more meaningful data to help us to improve services better still further. I just got a couple of questions just to sort of start things off. And clearly, you know, everything's going well, but I just sort of noticed a very small, and it may be just a sort of artifact, on page 54, the adult mental health services complaints, Windsor, Ascot and Maidenhead, just sort of coming up a little bit as an outlier. And I think in some of the community ones as well, Windsor, Ascot and Maidenhead, I mean, they're not big numbers, but can you just give any, you know, explain why that might be, or is it just one of those random things for small numbers?
Well, a couple of them are actually the same complainant coming back a few times.
Oh, right. Okay.
Which when I looked into that, because Martin, to be honest with you, I had the same query when I first saw the report, because it's not usual. There wasn't anything when I looked at them that I had a particular concern around.
No, okay. And just a couple of other things. One is I was delighted that community nursing services perform so well in terms of satisfaction, which is good news. But also on the ethnicity, it is on page, or is it just down a bit somewhere? The I think the Asian, it's on page 61, ethnicity, the Asian other, number of patients of age, it's all very small, but the percentage of complaints was quite a lot less in the proportion of the population who forms that category. And it's a sort of question that keeps coming back to me is, do we have confidence that people are not complaining. I mean, I don't encourage people to complain, but, you know, whether they're not properly complaining because they don't know how to, we don't make it easy for them, you know, for cultural reasons, or actually they are more satisfied, or do we have any sort of, or maybe this new tool of yours will help us understand this issue better?
Yes, I don't have an answer to that, Martin, if I'm really honest. I think it's really hard when still a quarter of our complainants, we don't know what their ethnicity is. So I've got no idea if that whole group of people don't want to. But I do think the new tool and helping encourage will be able to highlight much better from an experience perspective if we're missing out on cohorts of patients that we need to be tapping into, and then we can actually look at how we can go around that.
Okay, any other comments from colleagues?
No, I mean, I had the same issue as you on Windrescott and Maidenhead, but I think Debbie's covered it very well for me.
Okay, and then there's the appendix form complaints list, which gives more detail, and if anyone wants to raise anything, please do. And the 15 steps, and I'm always slightly on 15 steps whether it really tells us very much or not. But it's one of those things. It's sort of, you feel it ought to, and I know some people feel very strongly about it, but I'm never quite sure. I don't engage great debate now, but I just sort of put a question mark in my mind whether this is the best way of getting the information we're seeking or not. But Debbie may have a view.
It's one national way. Services find it quite helpful,
okay,
because it's totally unannounced, to actually give them some feedback. I mean, obviously you don't see the whole of the feedback that they get. You see a very small summary of it. So it's one method of gathering some experience data.
Okay, all right.
Martin.
Yeah.
Martin, could I just comment on that 15 steps? Because from personal experience, when I've attended 15 steps visits, I do find that they're very useful, and a lot of time and effort is put in from the people participating. However, when I then look at the board reports, I sometimes feel that they've been summarised and précised down to such a small amount of feedback to us. They feel almost quite cursory and too summarised in terms of the review. And I sometimes think that they are certainly worthwhile and very useful, but the report that's coming up to us probably needs to reflect the content a little bit more than just to try and summarise it in one sentence, which can give quite a biased view otherwise that they are superficial.
Yeah, okay, maybe that's the point that I was trying to get to, Mark. Thank you very much.
Yes, and I agree with Mark. Sorry, yeah, I agree with Mark. I mean, I find them assuring, enjoyable, and actually they're a good opportunity to catch people doing things right. You know, you quite often see unexpectedly good practice, things that you didn't expect to see. So I quite like that, and like Mark, I would think that, you know, the reports could drag that side of it out much better than they do.
Okay, sorry, someone else who's wanting to speak? No.
So Martin, just quickly, probably worth just, you know, an acknowledgement that because of social distancing, our board ability to do 15 steps and indeed visiting teams and wards, you know, is taken from us. And yet it is such an important part of our insight that we gather, and our assurance to a certain extent, but also our engagement with frontline staff. And it is what it is, but I think perhaps worthy of greater thought as we move ahead. You know, that there is no substitute, we know that, and there's no obvious solution, but we need to think about it.
I totally agree. I've got no magic answer, I have to say, but I think we need to work out how to do it as best we can. Thank you for that. Shall we move on then to the executive report, item 7, Julian's report. Julian, do you want to highlight anything, or do you want us to raise questions?
Really, just yes, one area really. The Simon Stevens, Amanda Pritchard letter will be picked up in recovery, which so we don't need to discuss that too much. The care homes has had national publicity, and I've given a summary of the position there. And in Berkshire, there's quite a lot of coordination going on now with the care homes. The item that probably is just worth touching on a little bit is the work David and colleagues have been doing on the response to COVID-19 on BAME colleagues. If anyone saw the All Trust broadcast, David gave a very good presentation, walk through the evidence, what we're practically doing as an organisation, and future plans on this, really. So I don't know how many people saw that, but it's probably worth David just giving a quick update about where we are with that. It is high-profile national topic and a concern amongst our network.
Yeah, David, if you could, please.
Yep, thanks, Martin. Yeah, so obviously we saw the media reports, and we were picking up concerns from our BME workforce around what they were reading in the media about the adverse impact of COVID-19 on people from an ethnic background. Initially, there was very little information or evidence in order to understand why that was or what the numbers looked like. We did get a report in about the third week of April, and a further one on the 1st of May. And they were evidence-based, and they did do some analysis that looked at what some of the causes might be. So we took that report and we used some of the findings from it to analyse how many people may be impacted by some of the things being found in those reports. So they were saying that males are more impacted by COVID than females. Also age, which you already know is a factor as well, with a higher risk profile. Obesity was in one of them as well, and then underlying health conditions. And also one of them did a further analysis about the different impacts on different ethnic groups, and that clearly showed that some ethnic groups were having a worse time than others, although all are being impacted to some extent worse than the white population. So based on that analysis, we took the risk factors of male, age, and the two highest areas of impact, which were Black Caribbean and Black African. And we did a trawl of the 1,111 BME members of staff that we've identified work in the trust. And that's highlighted 33 people that fit that criteria. So we're now carrying out interviews with each of those people to look at whether there are other risk factors that they might have about health conditions, about whether they've got high COVID exposure because of where they work or where they live. And as a result of those conversations, we'll put in place plans to support or protect those people. We've also now set up a work stream with a group of people that's meeting this afternoon for the first time that will look at any further emerging evidence. We've had another couple of reports that have come through. We're expecting another one from NHS England and NHS Public Health at the end of May that's going to take all of the analysis, all of the evidence, and come out with some recommendations of what NHS and Trust should be doing. And the work we'll be doing, we'll be looking further at risks for our BME staff, but also we want to look at what risks people might be exposed to if they've got BME members of family members or other wider networks, and also to look at our BME communities within Berkshire as well. So this will be a work stream that will meet probably initially every week, so we can develop our plan. We'll do further analysis, we'll look at the evidence, and then we'll put in place measures to review risks to keep our BME community updated on what those risks are and what we're doing about them. And that report that I put in was from last week, taking those first two reports that we had as the basis of the initial risk assessment that we've done.
Very good. I must say it sounds to me as though it's a very thorough action being taken, and also the all staff briefings that Julian referred to, with the ability to staff to ask questions, and I watched them, and some of those questions are about this issue. I think it's a great way of staff knowing they can raise any of these concerns if they wish to, so that no one feels they can't raise it, which is always a problem if it's suppressed somehow unintentionally. But I'm very pleased about the openness of this. And
There's,
thank you very much.
one area we've identified, which we're now looking into, which we didn't cover with the initial risk assessment, and that is anybody that works from us from an agency or from NHS professionals.
Yeah.
So we're just running a report now to gather the data from them to carry out the same exercise to identify if we've got anybody with a higher risk profile that works for us regularly from either an agency or from NHSP.
Yeah, okay. Thank you very much for that. Any questions for David?
No, I was very reassured by that, because clearly there's been such a lot of media speculation around this BAME issue, and I thought the work done there, reassured me significantly that A, we understood it, and B, we were doing something that was appropriate about it. That seemed to me to be the takeaway from that. So thank you very much, David.
Yeah, can I? Yeah, so similar feedback from me from the BAME point of view as well. Could we possibly just kind of talk a little bit more about the care homes? We jumped over that quite quickly. Obviously, it's an emerging piece of work, and you've said within the report, getting the full picture is going to take some time. Have you got any initial thoughts on where, what changes might emerge, or what differences in our services we might need to provide, if any, moving forwards?
Well, it's I mean, I can kick off. I mean, as I alluded to, it's obviously a complicated and fragmented market that was nearly on its knees before COVID. So, I mean, it's really important to think about, the state it was in prior to COVID. So we had a lot of liquidations, we had companies really struggling to meet ends meet, we had workforce shortages, and it was quite difficult to coordinate. So there had been some coordination across the ICSs with care homes, and the level of engagement was mixed in terms of that. So, for example, as part of our Digital Global Exemplar programme, we've been trying for about a year, 18 months to put, the ability to have video conferencing between our staff and care homes. And it took such a long time because these private individuals had different views around the usefulness of it, I guess, and everything else. So there's that sort of context about how that market is managed. And I think that's a fundamental strategic issue going forwards. It would have been beforehand, and now it's just been brought into sharp relief. But that is absolutely critical, and that the care pathway from acute care right down to sort of care homes needs to be equally as treasured, because actually the flow through the system is important. So I do think that care homes are going to have to have a higher priority, higher profile, and also a higher accountability in the system working, because they are an important resource. But it will be a bit like managing GPs in the sense that they will have different views because they're privately owned, but there will be a cost associated with the quality function. In terms of the immediate response, the CCGs, the local authorities have a statutory legal response in terms of care homes. But in terms of what's actually happening, is quite a lot of work is going on between health partners. So the CCGs and the acute providers and ourselves are providing quite a lot of support. Debbie, I don't know if you want to say any more about some of the specific bits that are going on in terms of infection control, as well as our usual support.
Yeah, so from both Frimley and Berkshire West have put in infection control support into the care homes, and they're also looking at support around PPE and general infection control issues, and also looking at staffing and other bits and pieces like that. We, as an organisation, we have more input into the west of the county because we've got the care home in reach team who have been continuing to work very closely with the homes, going in and supporting with testing of patients and the usual care, end of life care that we provide into there. So we're quite involved, more so from a west perspective, but there's a big piece of work going on. I think it was probably slower than it could have been to kick off it nationally. I think care homes were a bit caught out with this actually, but there's certainly a lot of work at the moment which is being coordinated across both ICSs.
Very good. Is that okay, Alan?
Just to add to that as well, we're also involved in testing as well. So we're supporting testing of people in care homes, which again they initially didn't get access to, and also now anybody that's discharged from one of our wards to a care home gets tested before they get moved. And also some recent guidance has come out. So there was planned as part of development of the PCN, the primary care networks, for GPs as part of their new responsibilities to do more work in reaching into care homes as well. And that was put back as a result of COVID, but they're now planning to bring that forward because that's been a bit of a gap as well within the provision in care homes.
Okay, thank you very much.
Martin?
One little thing, if I might just interject it, I think that we, and I don't know how we prepare for it or how much credence we even give to it, but there are certainly some views that say the care home, we've learned something from the first pass, if you like, of COVID through the population and how care homes have been impacted. And there is some concern, I think, I mean, when it's not so much a league table, but I looked at the prevalence of deaths in care homes, and some geographies like Hampshire have had very significantly higher deaths that per head of population than some others. And there is a view that if we have a second wave, that this, should we say, capacity that the care homes has provided, that's allowed some of the acute discharging that's been so important to the management of the disease in the acute setting, that some of these care homes might not be there to provide that in a second and third wave. You know, that almost that they might fall over and not be able to pick themselves up. And I just think that's something that I don't know how we do it, but having some kind of awareness as to, you know, what's going on with some of our local providers at CCG level, I would hope they're trying to understand that, because if all of a sudden half of the care home capacity ceased to be there, then the strain would push back straight through the system, wouldn't it?
Yeah, and they are absolutely doing that, and the local authorities, obviously, with their statutory role, are intimately involved with the sort of care home stuff. And yeah, the point you made is well made. You know, it's part of the flow, and is a crucial part of the capacity that we have in health and care.
Very good. Did someone else want to come in?
Yes, Martin. If we finished the care home discussion, may I just go back to the COVID risk assessment and, like everybody else, just say how welcome the trust response was, because if you look at the raw mortality data on BME and COVID, it's frankly alarming. It is, as David has just described, incredibly multifactorial. So my question is more general. We know that while many people want to get out of lockdown, 40% of the population actually want it to continue, and 20% of the population are not sending their children out. They're keeping them in because they're concerned. So there's a large chunk of the population who remains very concerned about their own safety and won't suddenly switch round when the government says it's safe. So my question is, if we have a member of staff who is concerned about their COVID risk, how do we deal with it? Do we give them a risk assessment? Do we just tell them we're from head office and it's going to be all right? How do we actually deal with that?
Julian, I think one for you.
I don't know. I was still laughing from David saying that expression. We're from head office. You'll be all right.
I'm a doctor.
I must try that and see what response we get there. No, I mean the approach we've taken, David, and David Townsend and Debbie come in, but generally from day one, we recognised that people would respond to this differently. We had the conversation, if you remember, David, Debbie, about if people were in a situation where perhaps they were up for redeployment and didn't want to go to a particular service, we didn't really able to just kind of push people along, that we would have that conversation and have a personal conversation about what was getting in the way. And generally that's, I think, what we do, isn't it? Have a personal conversation if someone was concerned or risky.
Yeah, absolutely.
Yeah. And we've done that with a number of staff, BME or other, where they might have underlying health conditions or they're carers for vulnerable people at home, and they're working in high COVID exposure services. So in those instances, we've had those conversations and we've made adjustments to people, or we've referred them to occupational health if they've got concerns about their own health conditions and where they might be working.
That's great. I mean, I do think it needs to be done through middle management, so that's good. Thanks.
Okay, thank you very much, David. I think it's a really important issue, and I think the culture of the trust that we're seeing, this openness and this willingness to go through what one might say are standard processes applied to everybody to look at risk, I think is very reassuring, because people know it's open, they know that they're going to get listened to, and I think that's half the battle on these sort of things. So thank you very much. Could we then move to finance, page 110, finance report, Alex?
Thanks, Martin. I'm going to refer you to page 114 of the year-end finance report. So we're looking at the 1920 year-end results here. This is pre-audit, audit's underway now. Pleased to say we achieved and slightly overachieved our control total for the year. So before PSF provided sustainability funding, we delivered a 300,000 pound surplus against a control total plan of a 400k deficit. So 700k ahead of the control total, and that's in large part to do with really good performance from across the trust this year, but also an additional sum of emergency mental health funding that we received along with other mental health trusts in March. So that was welcome, and we'll deploy that into mental health capital expenditure next year. When you apply then the provider sustainability funding we achieved both in the system and as a trust for delivering that control total, we delivered an overall control total surplus of 2.7 million against the original plan, including PSF of 1.9 million. When you take into account asset valuation impairments, primarily on Early House, our new leasehold Reading property, and Able Gardens, our wheelchair donated asset property, we'll be reporting a statutory surplus in the accounts of 1 million. Other highlights, just want to bring to the board's attention, we've overachieved against the stretch target around our SIP delivery. So we delivered beyond the NHSI 4 million requirement within our plan, and towards the 6 million stretch that we delivered in those plans that were worked up will carry forward once the NHS financial planning resumes normal business in due course, probably later on in this year or in the next financial year. We delivered a 10.3 million expenditure on our capital programme against the 12 million plan. The key schemes that slipped were the Early House development, in part due to the COVID impact of contractors in March. We were finally balanced about completion there, so a small slippage on that, and also on our learning disability ward move from Campion to Jasmine. We've been reporting that position throughout the year. All other capital spend in line with plan, aside from locality IT expenditure, where we've been resourcing new services and new starters. We've delivered our oversight framework risk rating of 1 in line with plan. The results for the year include £300,000 worth of expenditure related to our COVID response that we've been able to recover from central funding. And just in terms of month 12 movements, you'll note in the next page, on page 115, we have some significant variance movements within total income and total pay in month 12, and that is because NHS trusts have been asked to account for the change in employers' pension contribution rate from 14 up to 21% that the Department of Health have been covering in terms of costs, and for our accounts we've been asked to account for that. So there's an 8 million increase in income in month 12 and an 8 million increase in pay costs in month 12. Other movements in the month 12 position are narrated. They're broadly movements in provisions and non-recurrent costs that don't materially impact us going forward into the new year. Our pay bill has taken an upturn in month 12, in part due to the COVID response and temporary staffing, in part due to some winter initiatives, and in part due to our usual leave take up in the March period. those are the key highlights I'd want to report in the context for another strong performance and delivery of plan. Thank you. Happy to take any questions.
Alex, thank you very much. Can I just open? Firstly, it's a very good result, so thank you and your team and your colleagues. Very good. Are you able to give us any indications of what might come out in the next year or two in terms of the general direction of funding and the pressures on us? Or is that just too difficult to forecast?
It is too soon. We're directly connected through national webinars with the central team and the CFO, and I think we had an initial view around a break-even funding commitment from the NHS to its providers up until the end of July. It's likely that's going to extend to the autumn period, and if not beyond. So I expect a reset view on planning to start happening from the autumn, but at this stage there aren't any indications. And I think the best thing we can and should do at this stage is to really ascertain our underlying cost base and the changes that have resulted from COVID-related service transformation and service change that we can take forward, and in particular understanding the productivity transformation opportunities.
Absolutely.
And how they affect our cost base. And I would welcome doing that with the support of the FIP committee in terms of that cost base.
Well, clearly, anything we can do to improve efficiency must help our patients, because we can put more resource into the front line.
Yeah.
Any comments or questions, please, for Alex?
If I can.
Yeah.
Anybody else? Just a couple of things. The 0.9 PSF system related being on plan, does that suggest that the whole system has done acceptably well to hit its target?
So we were only linked to the Frimley system around system control total delivery, and the Frimley system of NHS providers and commissioners delivered its control total in the round. We were not connected to a system control total because Bob ICS was new in terms of its control total development and sign up. So that system performance is about Frimley.
Okay. In terms of the CIP, obviously great that we're ahead of target. We know that next year's plan, notwithstanding the fact that different funding arrangements around COVID might make some of this a moot point, and we don't know the answer to that. But it's almost slightly tiresome when you've got a large target yourself, and you actually then go away to find that a lot of the CIP that you delivered in the previous year sort of has evaporated. It wasn't recurrently delivered. So have you got in your head, have you got any thoughts around how much of the cost improvements you would regard as, if you like, permanent cost-based changes? And I suppose I'm thinking that they're about things like, the purchased healthcare, placement costs, and all those sorts of areas. How much of it do you think, is in the bank? We could adjust the budgets, it's fixed, and how much could sort of spring out at us again in later years?
So on specialist placements, there have been contract renegotiations and capacity changes that make those recurrent savings. On the short-term adult acute out-of-area placements, we're obviously going to need to monitor performance based on occupancy and length of stay within Prospect Park. At the moment, we're holding the position. We had some pressure during the year on our PICU unit, which didn't allow us to achieve the overall savings. So we're going to need to keep continuous review of that line in terms of recurrence, but it links to the optimisation of our beds within Prospect Park. So is a strategic intent, which operations will impact us, and in particular COVID may impact us around acute overspill if we get a potential surge in use of beds at Prospect. So we'll need to keep an eye on that. The procurement spend, the contract spends you can see on these CIPs are recurrent savings, as are the majority of the rest of those. So I think the main risk around recurrency is short-term out-of-area placements.
Good. So if it is a 6 million target next year, it's not 6 going on 10, because for this year's it's 6 going on 6 and a little bit.
These are broadly banked as recurrent savings.
Excellent. And two other really small things. The pension 8 million, is that a recurrent change to the way that we'll be accounting? Is that sort of just the way it's going to be going forward?
I think we need to check on guidance. This was late guidance to us in March.
Right.
So I'll be able to update Audit Committee, Chris, on that.
Okay. And the last one was Audit Committee. So the final, just to remind people that, is it the 27th that we've got the Audit Committee?
27th of May, yeah.
27th of May. So as usual, the final sign off of all of that and the audit clearance meeting is on the 27th, where in effect the board meets under the guise of Audit Committee. So Mahmuda and Naomi and I will be on that, but other NEDs don't feel you can't attend. It's not a closed shop. So we will be, Alex, I'm assuming that you'll be sending out a set of papers at some stage before the 27th, and we will be having that normal. I'll be honest, I don't know how you've done it, and I'm not going to ask, because to pretty much hit the same target, both internally and external auditors, is really, given what else is going on, is really quite extraordinary.
Well, as I say, Chris, the audit is ongoing, so I am holding my breath. Yeah.
Oh, right. Okay.
There's still time to find a problem.
Okay. Well, and frankly, 27th is so far ahead of the new expectation that if you have to shift it, don't even think twice. Don't put yourself through difficulty just to hit an artificial date.
Appreciate that. Thanks, Chris.
Alex, thank you very much. Any other comments for Alex? Questions?
Just a quick one, please, Martin. So, Alex, and this is a kind of statement of blindingly obvious, but I think helpful just to sort of lay it out in terms of expectations for the board. Just thinking about reporting going forward, and we can debate as at pace how we want to stand up the FIP again, as and when, and so on and so forth. But in terms of a framework for financial reporting going forward, and perhaps beyond financial reporting, but in performance reporting more generally, clearly things have changed, and we'll need a framework that works, that is simple but effective, and deploys a couple of key principles, including the need to account for COVID explicit expenditure. We've seen it in March, and yet March was a relatively short period as far as COVID is concerned, and indeed ensure that we're keeping a careful eye on continuing to drive efficiency through the organisation, so not skipping a beat there, and then thinking even more far ahead, and this might be a very premature sort of comment, but there is a world in which we eventually consider COVID as being part of business as usual. It becomes a very integral part of how we think and manage, in the same way that we might think and manage flu, for example. So just having that in our mind's eye going forward might be helpful too.
Yeah. Thanks, Naomi. And we've got a new reporting frame developed for month 1, and we'll share that into the 5th. We're going to be setting a forecast plan effectively, because the budget is held in line with national guidance, and we've got clarity around what's our underlying cost base and what is the COVID element of that as we come through in reporting. So yes, and look forward to sharing that with you.
Thank you, Alex. Very
good. Thanks, everyone. Thank you, Alex. Can we then move on to item 8.1 on page 123, True North Performance Scorecard?
Yeah, and just as an assurance to the board, you can see we're still reporting our usual corporate performance against indicators where available. There's only a few where data is not available. So in terms of the greyed out lines, those are greyed out either because we don't have the data available, and that's in relation to FFT for patient experience at this stage, and we'll keep that under review, or there's national guidance, and in particular around the financial aspects of planning, SIP and budget. We grade those out, but also where the operational focus and priority is in terms of what the COVID impact and response has had, for example, on our occupancy rate. We've agreed in the short term with David and his divisional ops directors that the focus isn't there at the moment. We're just seeing a natural reduction in bed usage for various reasons, and we'll keep that under review as part of the recovery planning and discussions with you and subcommittees. To that end, I think we also noticed an executive that the initial COVID response hasn't taken the eye off the ball off some very important true north indicators, but it has necessarily taken focus away to supporting redeployments of staff, to ensuring we're safe, to ensuring we're responding to the COVID infection response. So, for example, you'll see the falls rate there is continuing above target, and we expect in due course at the right time through recovery planning to support our divisions bringing back the right focus. I think we also need to be aware that because of COVID and potentially because of redeployed staff, we may see an uptick in some of the indicators around falls and other safety measures. And we're very cognizant of that, and we need to be very prospective around potential impacts of COVID going forward around those important safety indicators. Aside from that, I've highlighted kind of the key exceptions for the board on the cover, but very happy as my exec colleagues will be to take some questions on that.
Alex, thank you. I must say the cover sheet is very helpful with the bringing out the particular thing, makes it much easier to focus in. Any comments from colleagues, please?
I've just got one question, if I may. You've just mentioned falls. At one of the board meetings, I can't remember, but a little while ago, we got a demonstration or a display of the new technology to detect and therefore prevent or alert before falls. Did we get very far in the rollout of that, or was that kind of put on hold?
It has.
Oh, Debbie, go on. Yeah.
Sorry, Alex. So it's currently in West Berks Community Hospital, and we were due to roll out to Wokingham, and that is on hold at the moment, partly because it needs others coming in to support that rollout from outside companies, as well as the fact that we've got a number of deployed staff there at the moment rather than all of our usual staff, which makes putting in a new system quite complicated.
Yeah, I kind of assumed that would be the case, but I thought it was just worth asking, given the trends going kind of against where we had anticipated it would have been. Thank you.
Anything else? I've just got a question. Oh, sorry. Did someone have something?
No, I was just saying no.
Okay. I just got one, which is just one of interest, it's our intellectual interest, which you highlight on page 125 about the sickness rate, which looks as though it's lower than one might have expected. Do we yet have any sort of clarity about why that is? Or is that one of those things we have to learn our lessons a bit later?
I think we're studying that at the moment.
Okay.
That was a bit of a surprise in terms of the downturn in both the scale of the impact of COVID sickness is not as high as potentially it might have been, but also the non-COVID. And I think we're starting to see some potential sickness reasons in non-COVID around anxiety, stress, and some MSK issues that are popping through. So we'll need to keep that under review. And in particular, we're considering our remote working embedding at the moment. We've moved very quickly to about 2,000 people now able to remote work because of our IT enabling. We need to consider the other issues around ergonomics, safe working at home. Yeah. So definitely under review, but it's an interesting trend.
Okay, thank you very much. Is everyone happy to move on?
Yeah.
May I just, sorry, Martin, just quickly. This is a very open question. So it's about sort of what I would call COVID performance. So, and I know that the executive have been maintaining a sort of dashboard and some key performance indicators, which would shed some light on how we are managing that particular element of our service. So the open question is there merit in continuing with that? I'm sure the answer to that is yes. Is it something that we would want to integrate somehow going forward? Maybe just food for thought.
Yeah. Thanks, Naomi. And I think that we're considering as we move from a command and control gold view into recovery, what are the key data sets that we need to sustain us as we transition to new normal and recovery and reinstatement of services? So what are the key performance indicators around that may not be on the scorecard? Yeah.
Okay. Can we move on?
Yep.
Page 150, the COVID-19 recovery plan on the page. Catherine.
Thank you. You will recognise the bulk of this recovery plan. We have, and we were just talking about things like falls, we have maintained a number of the original goals, but we did feel it was appropriate in recognition of COVID to actually look at the annual plan on a page and update it within that context. So this is an updated version of the plan that you actually agreed at your February meeting. And for example, we've been talking about the importance of making sure that staff and patients are safe, and that remains one of our priorities. So what I'll do is I'll quickly take you through those goals that we've either included or amended to reflect COVID and the recovery phase that we're going through. So under True North Goal 1, harm-free care, the first is we will protect our patients and staff from getting COVID-19 by using appropriate infection control measures. That's particularly important when we start to think about how we will bring services back online. We need to make sure that as services come back online, where there are face-to-face contacts, that patients and staff will be safe within that context. We'll make sure that we have safe levels of staffing to meet service needs, and that's very much around the redeployment of staff and making sure that the skill sets are there, and making sure that the wards in particular, which are critical services along with community nursing, are safely staffed. And again, that's going to be very important when we start to think about recovery and returning staff to their substantive posts. So to give you a tiny bit of detail, a lot of the wards have been staffed by school nurses from the Children and Young People's Division. And of course, once schools start to go back, we will need to start returning staff. So there's quite a bit of planning and logistics that will need to be considered when we are looking at that. A big part of our recovery planning is the opportunity for engaging with staff and patients and carers around the new ways of working. So a lot of the services, and you'll see this in the recovery plan later, have gone big on digital and using things like one consultation. And the messaging we're receiving back is that they'd really like to be able to continue to engage with those ways of working. So we need to do an engagement piece with staff and patients about making sure that we can take those forward. Under the True North Goal 2, supporting our staff, sustain and improve staff engagement across all of our services, making sure the staff have appropriate skills, training and support for their roles. This is the changing roles and making sure that goes forward. And as Alex mentioned earlier, embedding remote working, making sure that staff can operate safely and effectively. Under good patient experience, we've included 2 new ones, using patient and care feedback to drive improvements in our service, and then supporting patients to manage any direct or indirect adverse impacts of COVID. You'll be aware that it's becoming more recognised nationally that there are actually non-COVID harms now happening to patients because they're not accessing services in the way that would normally. And then we've included a new one under Goal 4, Money Matters, transforming our clinical and non-clinical services using a digital-first approach, improving patient experience and streamlining our estates. So I'd say roughly half and half. So half are our existing goals that we feel are important. So for example, continuing to reduce falls, pressure ulcers, self-harm, inpatient services, suicides is an existing goal. But we've taken the opportunity to look at the response, and we felt it was appropriate to include recognition of the COVID. So this plan on a page has been shared with staff, and we have agreed that staff will complete their appraisals and set their objectives. So at the moment, staff are using this context to look at their appraisals and set their team plans on the page, recognising the recovery phase that we are in, effectively. So hopefully that gives you a quick whiz through the suggested amends to the recovery plan on the page, and I'm very happy to take any comments or questions.
We're going to discuss in more detail in part 2, but has anyone got any comments and questions at this stage? No? One of the things I've noticed, Catherine, and you've mentioned it, but I've heard it from 2 or 3 other services that I've been talking to, is the fact that some of these things that are being forced on us to do things remotely on, by digital means, etc., have actually people found better. I'm sure some they won't find better. The world isn't simple as that, but some of the ones that are quite interesting, I found people do seem to think it's better and they don't want to go back. So I think it'd be really interesting as we go forward to, and I'm sure we all support the digital first approach, is to try and be careful but clear about where these things actually, we do need to really push forward, and they are better for all sorts of reasons, not reluctantly better, but better all around. And some things where actually, frankly, they're not, and we just have to put our enthusiasm to one side. But that'll be a very interesting discussion, I think, going forwards. That's great. Okay, well, if we're going to discuss, we have a chance to discuss in more detail the emerging plans in part 2. So maybe we can move on if everyone's happy. Yeah.
Thank you.
Okay, thank you, Catherine. On to the draft annual report, which Julie has circulated. This, for formal reasons, we can't make this public until it's been laid before Parliament in July, so the papers remain confidential to us. We've had a chance to look at it. I know 1 or 2 of you have made some comments. Has anyone got any material comments to make about the report, or are you content?
Content.
Yeah, okay, that's fine. I'm sure we will find, or Julie will find, or someone will find, a typo here and there, but we'll have to sort that out later. I must say, in writing the introduction to the report, it has been an eventful year, but the 2 big events, our CQC outstanding and the response to COVID-19, both, I think, reflect very well on the executive and the staff's performance in the year. So I just want to, without being too flattering to the staff and the executive, just want to reiterate that actually this is, in spite of all the problems and difficulties caused to all sorts of people, I think the Trust has responded magnificently. So thank you very much for that. I'm going to move on then to Councillor Governor's update, if I may. If you remember, I put the Councillor Governors in abeyance right when we had the emergency. And I've been sending, as you know, short updates to governors by email. We intend, having discussed with the lead governor, we intend restarting with a virtual meeting on July the 17th. I think I've got that date right. Where we're going to use the technique that the executive have been using of a sort of broadcast with the opportunity to ask questions by typing. I'm sure that won't be ideal for all the governors, but I think this is sort of a first step. And then as governors get used to doing things remotely, because I think it's going to be some time before we can meet, then we can perhaps do a proper Teams meeting with governors asking questions directly as we do here. But I think we need to do it one step at a time. The lead governor is content with that, so hopefully we'll do that, and we look forward to non-execs joining us where you can. Item 10.2, use of the Trust seal, Alex.
Yes, to note, please, that's the learning disability ward move Campion to Jasmine and the refurbishment works.
Okay, thank you very much. Any other business? Debbie, could I just raise something about flu?
Yes.
Because I assume that looking forward to the next flu season, we'll be wanting to try even harder to ensure staff, a high percentage of staff are vaccinated against flu, so to reduce the, the dual problems we might be facing with a resurgence of COVID.
Yes, definitely.
I just put it down as a marker. I mean, I'm sorry it sounds a bit irritating to you, I'm sure.
It's not irritating at all, Martin. And actually, we were talking about it in the quality exec yesterday. So we always, way before now, have to be ordering the vaccine, starting to book meeting rooms for where we will be holding clinics, starting to look and plan about how we will deliver this. I mean, this year we're going to have to factor in how we might be able to do it differently, and the impact of a lot of remote workers, for example. So we're going to have to look at all that. But yes, planning is already underway.
Thank you very much. Anything else anyone wants to raise? No? Okay, thank you. The date of the next meeting is the Public Trust Board meeting. Oh no, the next meeting actually is the 9th of June. That's a discursive. And then the next Public Trust Board meeting is the 14th of July, unless Julie shouts at me. And we'll be streaming live on that one to give the public the chance to see us in action and ask questions. So we'll finalise those details in the coming weeks. And so now we'll adopt our normal resolution to exclude the press and public from the remainder of the meeting, as publicity would be prejudicial to the public interest by reason of the confidential nature of the business to be conducted. Thank you very much, everyone. And we're now going to leave this meeting, and then you'll need to re-click on the link for the part 2 meeting. And I suggest we have perhaps 10 minutes break between now and then. So say it's 20 past 11. Would that be all right?
Smashing.
Thanks, Martin.